evening, everyone, or good afternoon if you're on the West Coast. I am Andrea Baer, the Executive Director of Mending Hearts, and we are here today to wrap up our 6-part series on managing your LDL cholesterol numbers. And today is going to be a fun day because we're going to get expert answers to your frequently asked questions about managing your lipids. And we have some great presenters who are going to be with us to answer any questions that you have. And so before we get started, I just want to give everyone a few little housekeeping notes. All attendees are in listen-only mode. And so if you want to ask a question, you can type the question into the chat box anytime during the presentation. And if you have questions now, feel free to type them in. I will read the questions during the question and answer period. Right now, if you can't hear me, you can read this on the slides. Check the audio button on your personal computer to assure the sound is on. That's a big problem that we sometimes have. And then also the PDF version of the slides, as well as a recording of this presentation, will be available on the Mending Hearts website following the event. It typically takes 1 to 2 days to get it edited and up online. So check in late tomorrow, early Friday, and we should have it for you. Before we get started, I just want to introduce the 3 organizations who have partnered together to bring you this series. We are Mending Hearts, and our mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. The National Lipid Association, or NLA, their mission is to enhance the practice of lipid management in clinical medicine, and also the foundation of the National Lipid Association. Their mission is to improve the welfare of patients and families affected by cholesterol and high triglyceride problems. And we are very honored to have together today Dr. James Underberg. He is a lipidology and cardiovascular disease prevention specialist, a diplomat, American Board of Clinical Lipidology, clinical associate professor of medicine at the New York and NYU Medical School and NYU Center for CV Prevention. And he's the director there, sorry. The Bellevue Hospital Lipid Clinic in New York, New York. Thank you, Dr. Underberg, for joining us. Also, we have with us as a patient representative, an expert patient, Ron Manriquez. He is the president of Mending Hearts. He is also a patient who has had his battle with keeping his cholesterol low, and he's had a lot of great tips for us in the past, and we're excited to have him here today. I am Andrea Baer, and I am the Executive Director of Mending Hearts. So I am first, before we get started, we're going to do a little pop quiz, and it's always fun. There are no grades, but we would like to know how knowledgeable you are about lipid management. You can use your computer and just give us your response. We'll leave it open for just about 30 seconds, and so you might want to hurry up and think about it. I can say that before this webinar series, I was probably not just a little somewhat knowledgeable, but I feel like I've learned a whole lot over the last 5 webinars, and I assume that today will be just the same. So we're going to close this in just a moment. So if you want to register your vote, go ahead and do it now. Right, and so we are going to close our poll. Thank you. All right, so without further ado, I'd like to turn it over to Dr. Underberg, and we will give you the floor.
Oh, thank you very much. It's great to be doing this program this evening. I thank you, Andrea, for the kind introduction. I'm an internist and a lipidologist, and I see patients at NYU and Bellevue hospitals. I'm very lucky to be part of a great group of clinicians both physicians, nurse practitioner, registered dietitian, pharmacists, all working together as a team to help prevent cardiovascular disease. A little more about my background. I'm the past president of the National Lipid Association and the vice president of the foundation of the National Lipid Association. And we're really lucky to be able to do this program with Mended Hearts, because that's why we do all of this, is for patients. And without patients and their input and their role in driving the direction of where we're going, we wouldn't be able to do any of this. So I thank you for allowing me to be part of this program this evening. Answering questions, it's one of my favorite things to do. Often I'm talking to other colleagues if I'm not talking to patients. And so we're going to hopefully answer a lot of your questions today. These are my financial disclosures. I do a fair amount of clinical research teaching, and that's where a lot of this comes from. Next. All right. So here's our frequently asked question number one. My doctor told me that based on my blood test report, a statin wouldn't work for me, and I should make lifestyle changes instead. And before I even get to the bullet points on this, the first thing I want to say is that lifestyle and medications are never either or. I always say to all of our trainees and any patient I am interacting with that anytime we talk about medications or pharmacologic interventions, that's always the best time to talk about non-pharmacologic interventions, meaning lifestyle, diet, exercise, stress management, weight management. All of these things are an important part of not just managing cholesterol, but reducing cardiovascular disease risk. And you can't do one without the other. So with that in mind, the bullet points here is why would a statin not work? I would tell you that it's very, very rare that a statin would not lower someone's cholesterol. So I suspect what this question is getting at is more that a statin wouldn't be appropriate for me rather than it wouldn't work. And appropriateness of statin use has to do with why do we put patients on statins? We start statins to lower cholesterol, but that's because statins have also been shown in the right population of patients to reduce the risk of cardiovascular events, heart attacks, strokes, death from heart attacks and strokes. And so who benefits the most are patients who are at higher risk of having a cardiovascular event. Someone who's already had a diagnosis of heart disease, or in some cases, people with a variety of risk factors for heart disease, such as diabetes, hypertension, inherited high cholesterol, something called familial hypercholesterolemia, chronic kidney disease, and a variety of other associated risk factors, elevated lipoprotein A. So in some patients, if their risk is low, and I would also in some cases put young people who don't have risk factors, the benefit of a statin might not make sense in that patient. And I think that's probably what this question is alluding to. As far as lifestyle changes, it all depends on what someone's lifestyle is to begin with. And that's where listening comes into play. And I would tell you that small changes are the best. Trying to do too much too quickly is a recipe for failure. It's taken me a long time to lose weight I wanted to lose. And it took a lot of starts and stops to do that myself. And when I talk to my patients and counsel them, we focus on a variety of different things and what makes the most sense for that patient and what can they do and what can't they do. And so dietary changes, sometimes working with a registered dietitian, and registered dietitians are a big part and component of the National Lipid Association and our team, can be extremely helpful. And a heart-healthy diet, sometimes cholesterol modification. Some people benefit more than others from reducing cholesterol, saturated fat, increasing exercise, maintaining a healthy weight, smoking cessation, stress management, sleep management. All of these things are part of lifestyle changes, moderation in alcohol, etc. So we could spend a lot of time talking about this, but I think that's what someone's getting at with regards to statin and lifestyle here. Any comments from the panel on this? Okay.
Yeah, no, I think that's great.
All right, so let's move on to the next question. Are there any negative health effects of being on statins long term? And I think this dovetails very nicely with the first question, which is why a statin might not be appropriate for someone. Because when we look at an intervention like starting someone on a medication, in this case a statin, we think about benefit and we think about risk. And I always tell people there are no drugs that are side effect free. However, I think there are ways we can mitigate side effects, and we can also inform people about what is really what we call something clinically relevant and something that maybe might not be. And so there are certain things that I think statins have been associated with. The most common are musculoskeletal complaints, primarily what we call myalgias or muscle aches. And the frequency of these depends on how you evaluate. If you do it in a trial where you've excluded all of the people who can't possibly have a problem, the rates are very low. If you look at real world data, it's probably anywhere between 5 to 10% of patients who get started on statins can develop muscle-related side effects. They tend to be achiness, soreness. I tell my patients it's almost like you went to a gym and you started a new exercise program, and a day or two later, when you tried to put your jacket on, your upper arm muscles were sore. And so these tend to be the proximal muscles of the upper extremities, meaning the arms, the upper arms, or the thighs. Some people get a little weakness. We watch our patients as they get up out of a chair. If they need help getting out of a chair or need to push with their arms, that can be sometimes a side effect of statins. And these typically happen relatively soon, within 1 to 2 months after starting a statin. And they tend to go away when you stop the statin. And then when you re-challenge and add the statin back, they come back again. And that's typically how you make the diagnosis of statin-related myalgia or muscle complaints. We call this SAMS, S-A-M-S. I always remind people that you have to remember that sometimes when someone is started on a statin, the first thing a lot of my patients will do is say, well, I've got to make those lifestyle changes too. And suddenly someone joins a gym, starts working with a trainer, and does an exercise program they haven't done in a long time. And so that muscle-related complaint may not necessarily be from the statin. It may be from a new exercise program someone's on. So it's always important to really tease through someone's symptoms and what they're doing and make sure that there aren't other causes of those muscle-related side effects. Statins don't cause arthritis. They don't cause joint pain per se. So if someone has a history of arthritis, it's unlikely that statins will make them worse. The second thing that I think is real, but probably not clinically relevant, is statins can slightly increase liver function tests or liver blood tests. But statins are not associated with liver disease. They don't cause liver disease. And the reason statins slightly raise the liver blood test is because statins are metabolized by the liver. And so just like if we measured your liver test right after you drank some alcohol, the liver test would become abnormal because alcohol is metabolized by the liver, so are statins. And it's normal to see a slight increase in liver blood tests. And in fact, the FDA weighed in on this a while ago, and they told doctors to stop checking liver tests all the time once people are safely on statins. We do it prior to starting statins because statins are metabolized by the liver. So if someone has liver disease, we want to make sure that everything's stable before we use a statin. But monitoring liver function tests on statins is no longer required by the FDA. And some people still get their liver function test measured, and it might go up and it might go down. If it goes up significantly, obviously one would want to stop the statin. But it's more of a laboratory phenomenon than really an adverse effect. The next effect I want to talk about is blood sugar. Long-term statin use, especially at higher doses of more potent statins, has been associated with slight increases in blood sugar. However, statins do not cause diabetes. All they do is maybe push someone slightly over the edge. A nice way to think about this from a statistical standpoint is that if someone is going to become diabetic, over the course of their lifetime, they may become diabetic 6 weeks sooner if they're taking a statin. And we do know that diabetic patients are one of those groups of patients that benefit to a greater extent with regards to reduction in heart attack and stroke when they're on a statin. So I would never not use a statin in someone who is diabetic. And if someone's blood sugar went up very slightly, I do not think that that is a clinically relevant side effect. It's one that we tell people about, and it's one certainly that one wants to pay attention to. And it's another reason that it's important to follow appropriate lifestyle recommendations, even if you are taking statins. Statins aren't a license to then stop exercising and eat anything you want and gain weight. So I think those are the three most common things. The one that comes up a lot is, can statins affect memory? We call this neurocognitive side effects. And the answer, I don't think so. There are some reports to the FDA of statins causing mild reversible, what they call cognitive defects. The FDA's recommendation is that if that happens, you should stop the statin and wait a month. If those symptoms persist, then you need to see a neurologist because it's not the statin. But I would tell you that if you look at long-term data in people who have either dementia or dementia-related symptoms, they seem to do better on statins, not worse. And so, again, I do not think this is a significant side effect. But again, anything can do anything to anyone. And that's what I always tell my patients. And so we're always very careful. If someone feels or believes that a medication is causing a side effect, they're not going to take it. And so the way we address that is that we stop the medication, look to see if the side effects go away, and then we try another medication. And there are 7 different statins. They're all slightly different. They're all metabolized slightly different. And there's no reason you can't try another one, or you can't try one that's a little longer acting or shorter acting, or maybe dose them a little differently. And so there are a lot of options when it comes to statins. So I'll pause here and just ask, any thoughts from the panel on this, or should we proceed to the next question?
No, I think that's great.
Okay, so let's move on. Our third question here is, my cholesterol raised 70 milligrams per deciliter after menopause, but my lifestyle and diet have remained the same. Why? And this is actually one of the most common reasons patients are referred to me as a lipidologist, is an increase in cholesterol after the menopause. And so we don't really know for sure why this happens. We know it does happen in some women, but not all women. One speculation is that as estrogen levels go down, as women pass through and become postmenopausal, estrogen levels, as they go down, essentially the body tries to fix that problem. And the precursor of estrogen is cholesterol. And so making more estrogen from cholesterol requires more cholesterol as a substrate, as we call it, or the supply chain needs to be increased. And one of the places that we get cholesterol from is the intestine, where we typically absorb about 20% of the cholesterol that gets into our intestine from dietary or sources from the bile, where we excrete it from the liver. And often what happens after menopause is that women increase their absorption of cholesterol. Typically, not only does the LDL cholesterol go up, but the HDL cholesterol goes up. HDL is made primarily in the intestine. And so an increase in the LDL and the HDL after menopause often is a signal that someone has increased their absorption of cholesterol. And so while reducing dietary cholesterol will not lower cholesterol for many people, it will in someone who is a hyperabsorber of cholesterol. And we often counsel women post-menopause on reducing saturated fat and cholesterol. But also there is a particular medication that targets cholesterol absorption, and it's called ezetimibe, and it used to be called Zetia. It's now a generic medication, and it blocks absorption of cholesterol. And sometimes we will add this to statins in women after menopause. And we also know that women catch up and pass men when it comes to risk of heart disease after the menopause. And this may be one of the causes, along with the reduction in estrogen levels. So I just thought I'd throw that out there. But this is a common thing that I see in my practice, and it does need to be addressed. And oftentimes what I see is women will come in and they say, well, my LDL went up, but my HDL went up too. And I've been told not to worry because the HDL went up. And my answer is that's not the case. We do not know that HDL protects from that increase in LDL, and it still needs to be addressed.
Great, thank you.
Okay, next slide.
Thanks.
Oh, this is one of my favorite questions. Do you need LDL cholesterol for brain function? Are there studies that prove it is or is not needed? And I'll tell you, the best study at all is the development of the fetus to a newborn, an infant, and a toddler. When is our LDL cholesterol the lowest? It's when we're born. And when is the brain function developing at its most rapid rate? Right when we're born and in that first couple of years of life. And that's when our LDL is the lowest. So when people ask me about LDL cholesterol and brain function, I remind them that when the brain is growing the fastest and the synapses are connecting and everything is doing what it's supposed to do and we're learning language and we're learning behavior, that's when our LDL is the lowest. The brain is an independent corporation, and it makes all of its own cholesterol that it needs, and it does not need to source it from anywhere else. And that's a unique thing about the brain. Every cell in the body makes cholesterol except for one, and those are red blood cells. But the brain makes all the cholesterol it needs. LDL does not cross the blood-brain barrier, as we call it, the ability of systemic circulation to get up into the brain. LDL does not get there. And so when you lower LDL, it doesn't affect brain function. When you raise it, it doesn't supplement brain function. And the brain controls its own levels of cholesterol. There are studies, mostly done with medications called PCSK9 inhibitors. We have two of them that are out there now, one called alirocumab and one called evolocumab. And a study done with evolocumab in patients with heart disease, it was added to the statins. They actually looked at a pre-specified group of patients who were taking the drug and who also got to extremely low LDL cholesterol levels. And they did pre-specified what we call neurocognitive testing, memory function and behavior function and recall and a whole bunch of other things. And they were able to show that in the group that got the PCSK9 inhibitor, there was no change in neurocognitive function. And in the group that got to very low LDL levels, no change in neurocognitive function. So I think the data and the physiology support the fact that you don't need a lot of LDL cholesterol, A, to live, and B, the brain regulates its own LDL cholesterol and does a fine job with that.
Fascinating.
One of my favorite questions.
Yeah, that's fascinating, and that's something that we didn't know, so that's great. All right, question number 5.
Oh, now we're getting into size. A lot of people have sometimes what we call lipoprotein testing, or some call it advanced cholesterol testing, although I hate that term because there's nothing advanced about it. This is something we've known about for years, and it speaks to the difference between lipids and lipoproteins. You know, cholesterol is a fat, it's an oil. And despite what people think, it doesn't float in the bloodstream like logs in a river. And the reason why is because the bloodstream is essentially water. And anyone who's done any cooking knows that oil and water don't mix. And so cholesterol does not float in the bloodstream. It needs to be transported around in the bloodstream inside little water-loving vehicles or particles. And these particles have names we already know. One's called LDL, one's called HDL, one's called VLDL. And they kind of carry the cholesterol around from point A to point B, kind of like boats on a river or cars on a highway. And we can actually measure these particles, and we can look at their size. And some people have smaller size particles, some people have larger size particles. The bottom line is that the size of the particles does not determine risk for heart disease. The number of particles probably does. And when you have smaller particles, you often tend to have more of them. But if you have too many large particles, you'll get heart disease. And if you don't have a lot of small particles, you won't. And in fact, patients with familial hypercholesterolemia, a genetic cause of high cholesterol that's associated with premature heart disease, have very large, fluffy particles, and they still get heart disease. So this sizing of particles, I find to not be particularly useful, other than to people like me who want to get an idea potentially of what the cause of the cholesterol problem is. But I tell my patients not to worry about it too much.
Great. Thank you. Okay, question number 6.
How can you increase your HDL-C, which stands for HDL cholesterol, and is it worth the focus? So this is interesting. There are a lot of things that will raise HDL cholesterol. Some of them are actually associated with reducing the risk of heart disease. 2 of my favorite examples are exercise and stopping smoking. If you stop smoking, your HDL will go up, and exercise will raise your HDL. But it's unclear that the benefit is related to the change in HDL, because when we measure HDL cholesterol, we're measuring a value that doesn't really accurately represent what good or bad things HDL is doing. And people often think of HDL as being protective, but the value that we measure when we measure HDL cholesterol is not a value that actually informs us on whether or not HDL is doing good or bad things. So what I always tell people is things that raise HDL are associated with better outcomes and reduction in risk of heart disease, but don't worry about the effect on HDL. As an example, if you increase the saturated fat in your diet, your HDL will go up, but so will your LDL. So I don't know if that's a good or bad thing, but we do know that increased saturated fat in the diet has been associated with poorer outcomes in some cases. On the other hand, you can drink a lot of alcohol, and that will raise your HDL cholesterol also. The more alcohol you drink, the higher the HDL will go. But it seems that only small amounts of alcohol have beneficial effects on cardiovascular disease. And so again, I think it's better to focus on the behaviors rather than the number. And one of the things we've learned about HDL cholesterol is that medications that raise HDL cholesterol have not necessarily been associated through HDL cholesterol with benefits on reduction in heart attack and stroke. Now, those same medicines may potentially lower LDL cholesterol, and that's where their benefit may lie. But we've stopped trying to raise HDL cholesterol in my business with medications. And when it comes to behavior and lifestyle interventions, we do it for the intervention, not for the number. I don't know if that answers the question. It's a long answer to a short question, but I think it's very important. And the corollary to this, by the way, is that having high levels of HDL cholesterol doesn't necessarily protect you from things like heart attack and stroke. And so if your HDL is high, but you still have a very high LDL, or you have diabetes, or you have high blood pressure, those things need to be addressed independent of the HDL cholesterol. Estrogen raises HDL cholesterol also, and we don't use estrogen to reduce the risk of heart attack and stroke. So hopefully I've answered that question for you.
Great, thank you.
Okay. So I've been on Lipitor and its generic, which we now call atorvastatin, for about 30 years. There's a Crestor, which is actually now called rosuvastatin. All of these statins, except for one, are now generic. More effective, and should I switch? So the first thing I say about statins is they're all good drugs, and they're all a little different. They all work through the same mechanism, but they all have slightly different effects on things like the liver, kidneys, a variety of other ways that the medications are metabolized, their half-life, how long they stay in the system. Some of the older statins have to be taken in the evening. Some of the longer-acting statins, like atorvastatin and rosuvastatin, can be taken at any time because they're long-acting. Of the statins, rosuvastatin, Crestor, is the most potent. and atorvastatin is right behind it in potency. And I would tell you that the difference between atorvastatin and rosuvastatin in potency is not that much. However, some people respond differently to a statin versus another statin, just because there's a slight difference in the way the medication fits in their body's metabolism. These medications all work in a lock and key kind of mechanism with particular individuals. So if someone is doing well on Lipitor or atorvastatin, and their medication is being tolerated and it's lowering the cholesterol the way we would want with no side effects, I don't know that I would switch them to rosuvastatin. But if they weren't getting the effect they wanted, then changing them to a more potent statin, which is rosuvastatin or Crestor, is a reasonable thing to do. Rosuvastatin, one interesting thing about rosuvastatin or Crestor is that there is no interaction with grapefruit juice with Crestor, and there is with Lipitor. So if someone is a big grapefruit juice lover, then Crestor might be the preferred, or rosuvastatin might be the preferred medication for them. The second half of this question is I also take Zetia, which is also now generic, and we call it ezetimibe, and my LDL is over 70. So I would tell you that if someone was on atorvastatin and ezetimibe, and their LDL was over 70 and they had cardiovascular disease, heart disease, then the threshold for doing something more is that the LDL is greater than or equal to 70. And so in that case, making the switch to a more potent statin might be reasonable, or potentially adding another medication. Of course, always stopping to talk about lifestyle and diet. Making sure people are being adherent with their medications is just as important as making sure they're on the right medications. Ezetimibe is very well tolerated. It's not as potent as statins, but it works well when combined with statins. So it's usually our next line of therapy after a statin.
Great, thank you. All right, next question.
All right, I'm a success story as far as tolerating Lipitor and reducing my LDL to about 60, I'm guessing, milligrams per deciliter. However, it didn't solve my blockages. I'm guessing this refers to maybe plaque in the coronary arteries, the arteries around the heart. I've always had questions about the lack of correlation between the lower cholesterol reading after taking the Lipitor and the continued blockage of my coronary arteries, So this is another great question. And I think it speaks to making sure that we all understand why we take these medications. If someone has pre-existing atherosclerosis, obstruction or plaque in the arteries around the heart, that puts them at increased risk for having a heart attack and a stroke. And we do know that taking statins and lowering the LDL below 70 milligrams per deciliter, and maybe even lower, reduces the risk of having heart attack and stroke, and even dying from heart attack and stroke. What's interesting is that reduction probably relates not to making the plaque go away, but to stabilizing the plaque. Because the way people have heart attack and stroke is that pre-existing plaque destabilizes and opens up and ruptures. And the contents then spill into the artery and then swim downstream to the narrowest part of the artery, where then they occlude it or block it. And that's what leads to the heart attack, or if this happens in the brain, a stroke. And so it's stopping the plaque from opening up and rupturing that is the key to preventing cardiovascular events. And that's what statins seem to be particularly good about. They stabilize plaque, they prevent it from progressing, and they stop it from rupturing, or they stabilize the plaque. And inherent in stabilizing the plaque, they sometimes make it more dense and convert it from what we call soft plaque to harder or calcified plaque. And in fact, one phenomenon that we often observe is people who get coronary calcium scans. They're really meant to be done before people are on statins, because in some cases on statins, people's coronary calcification can worsen as the plaque becomes more stabilized and less likely to rupture. And that's not a bad thing. And so We don't try to make the blockages go away. In clinical trials, there's some data suggesting that if you make cholesterol levels extremely low, getting them down to below 40 and even 30 for the LDL, you can regress plaque. But there's no data to suggest that those patients do any better from a perspective of preventing heart attack and stroke. And so this is a really key, important point to make sure people understand about cholesterol lowering, especially with statins, which is that what we're trying to do is reduce the risk of events, not treat something that we see on a scan, so to speak.
Great, thank you. All right, so I think that brings us to the end of the questions that were submitted prior to the webinar. I'd like to take a moment and ask Ron to give us just a few minutes on his journey with cholesterol management, and then I had a couple of questions for him, and then we will start taking questions from the audience. So Ron, would you like to introduce yourself and give us some information about you and your journey?
In the 40s, I decided that it was time to take my medication, but it was probably too late because soon after that, I had a major heart attack. I hadn't changed much. I took medication before and during that period of time, but having a major heart attack really get me to stand up and notice. And it took me a while to recover. So I've been on medication, and the balance between that is diet and exercise, which is important, and continue with that journey. Recently, I had a angiogram this past November, and of course, things haven't improved much, which gives me more concern. But I'm on a statin of 80 milligram, which it keeps me stable, and the other medications I got are Renexa, isosorbide, atenolol, and lisinopril. And the new one was Vasepa, which so far my cholesterol count is down to 103. But the other two numbers are kind of borderline. The HDL is 39 and the LDL is 50. So I'm on this journey that I can't give up. But I find out that medication alone doesn't do it. You have to do the combination of diet and exercise, which my daily mantra is to do exercise daily and then watch my diet. I'm a vegetarian and I do have occasional fish. And I wanted to lead a normal as possible life, but with the last sent to the hospital, I started getting more and more concerned. So I'm also on the situation to lose more weight. I'm trying to get down to my college weight, but I'll never make that. But I have this goal of trying to get there, to try to live a normal life and not be inhibited by my heart disease. With the cholesterol at 103, I'm wondering if that might be a little too low, but I guess with the other two numbers that are borderline, it would be okay. And then my A1C is at 6, which he's telling me it's borderline diabetic, so it's also getting me on this weight loss situation. So I continue with a lifelong struggle. So when I talk to folks about heart disease and cholesterol and managing their chest pain, and it's always the combination. I don't focus on medication because you'll find some folks will just say, well, I'm taking my medication, but it's okay to have eggs in the morning and a steak dinner, right? Well, it's not. And it's okay not to exercise. You do maybe once a week. Well, it's not. In my understanding, you should be doing about 30 minutes a day, at least 5 days a week, which I try to tell people. And they understand if they don't listen, which sometimes they don't listen, inevitably, if they've already had a situation where they're high risk, they will have a heart attack. And I never tell anybody I told you so. I just get to the point where I try to help them through that. And being involved with Mending Hearts, you have a lot of folks that have, well, all of us have heart disease. It's the only organization that you join with heart disease. So that's my story very quickly. And if there's any questions, I kind of laid that out. But I do believe that the combination of exercise, diet, and medication are critical. And maybe 1/3, 1/3, 1/3. But if you give up either one of those, you're in danger, as for me, to try a second heart attack, which possibly won't survive. My angiogram was not good. And I do have clogged portions of plaque in my arteries, which are on the corner. So he wasn't able to put any stents in. So I'm stent free, which back in the day, that before they had coated stents, They have coated stents now. I never did get stents in, so it's kind of a track that I continue on. So that's my story.
Thank you, Ron. I think that's great. I just have one question because you did answer the other question, so thank you. What has been your biggest challenge in managing cholesterol from a patient perspective?
The biggest challenge is before we had COVID, right? That we went out to eat a lot, and that's fun. And you go out with friends to eat, and that's fun. But the fact is, restaurants really don't care about what they put in their food. They just care about that it tastes good. And that was always my weakness, and to go out to eat and try to manage that. So you can change your eating habits by going out occasionally, but you do have to manage your diet from home and do a gut. And also when I travel, it's always hard because you fall right back into eating out, and they don't make cholesterol-free food. They don't have lower cholesterol. They put a lot of oil and fat into takeout food. So my biggest challenge is watch my diet. I'm on so much medication now that I hate to take more, but with a cholesterol count of 103 overall, I think I pretty much got it managed. The other two, it's going to, I think, drop or raise accordingly when I lose more weight and when I get down to my college weight, which should probably be another 10 pounds, but it's been tough.
Great, thank you. All right, so we do have some questions from the audience. I will start asking those. The first one is, I've listened to several webinars, lectures, etc. on lipids and healthy and eating healthy. However, they always emphasize green leafy vegetables and other things. But I am on warfarin, as are so many others. It could help if you could speak to substitutes for the high in K vegetables to help us eat healthy.
All right, so I would say this is where the team-based approach and partnerships come into play. And this is where I have ultimate respect for my colleagues in the registered dietitian world, particularly those who have an interest in heart disease prevention and lipid management. And they can be extremely helpful when dealing with the specific aspects of a particular patient's diet. And I always say that a really good registered dietitian listens first, listens to what someone's dietary habits are like, what their likes and dislikes are, speaks to the provider who's managing the patient, so understands what the goals are, and then comes up with a plan that not only works for the patient, but it is safe based on the medications that they're taking. The National Lipid Association keeps a list of registered dietitians, but most registered dietitians in the community can handle these issues and problems. And that's where they really come in handy. And so this is where I would say as a physician, I get help. And it could be other situations. There are a lot of dietary issues that come into play. People have underlying gastrointestinal disorders, they have bone disorders, they have liver disorders or kidney disorders, and one size doesn't fit all when it comes to nutritional recommendations. And that's where getting help from experts can really be useful. And a good dietitian won't simply tell you to avoid this or avoid that. They'll give you what they call macro recommendations, where they'll actually work with you on a food plan. What do you like? How can you eat what you enjoy in a way that works for you and is safe and healthy?
Great. And another question on the same topic of diet. Are there resources out there for people who are looking to lower their LDL using simply diet? And I think we've already answered the question that we can't just do it on diet alone. Right. But the patient is stating that they can't tolerate statins, even shots in lower doses. The question is just, how do they do that with just food? And I assume that we can't do it with just food alone. But can you talk to what other options may be available if they aren't able to take a statin at all?
Right. So I would say that one of the mistakes, not mistakes, but one of the unfortunate things I see often is that when someone has tried statins and been unable to take them, they kind of stop. And as a lipid specialist, that's frustrating to me because we do have a lot of other options now. When When I finished my training many moons ago at Bellevue Hospital, when I was a young intern and resident, we only had niacin and something called bile acid sequestrants, something called cholestyramine, which was this grainy powder that you had to mix up and drink, and it made everyone constipated and miserable. Niacin gave everyone hot flashes. And then we had statins, and statins were a game changer. But since statins, we now have ezetimibe, we have PCSK9 inhibitors, we have a brand new medication that's been available for a couple of months now called bempedoic acid, which can be given alone or in combination with ezetimibe. And then I heard Ron mention that he's taking Vasipa, which is EPA, eicosapentaenoic acid, which is a fish oil, marine-based fish oil, which doesn't lower cholesterol, but reduces the risk of heart attack and strokes in people who have cardiovascular disease. So there are so many other options out there now that are available that stopping at statins just isn't good enough anymore. And if that's kind of where you are, then I do think that's where you need to seek out help with someone who has a little more expertise and wants to go a little further with you.
Great. So the next question is, can you address the increase in CK levels? I'm not sure what CK stands for, maybe you do, specifically in athletes and runners.
Right, so CK stands for creatine kinase, which is an enzyme produced by skeletal muscle, produced by actually a lot of other muscles in the body too, including the heart. But in this case, I think the question refers to the skeletal muscle related increase in CK. And anytime we injure our muscles, for good or for bad, CK levels go up. If you go to the gym and you lift weights, the way that you build muscle mass is by the muscles being torn and then repairing. And every time those muscles tear, whether it's from lifting weights or it's from going for a run or it's from doing sit-ups or whatever it is that you're doing, there's a slight release of this enzyme called CK into the bloodstream. Turns out that statins also increase CK, and they're more likely to increase CK in people who do things that increase CK. So if you're a marathon runner, or you're a professional athlete, or you're someone who works out all the time, you're probably going to have higher CK levels on average than someone who doesn't. And a statin added onto that might increase your CK levels even more. But it turns out that asymptomatic increases in CK, certainly at the lower end of the scale, are not associated with adverse outcomes with statins. There is a very rare side effect with statins called rhabdomyolysis, where independent of exercise, statins can cause severe muscle breakdown, which leads to kidney disease. As I said, it's very uncommon. I've seen it twice in almost 30 years. But it's something that's worth knowing about. But monitoring CK levels is not something that we do. Sometimes people come to me and they say, I'm a marathon runner and I'm a statin. Should I take my statin before my marathon? Usually what we do is we tell them not to take it for the day or two before the marathon. But other than that, I don't think that it represents a major issue.
Great. Okay, so this one is, my lipid panel has improved on statins, but my triglycerides are rising despite limiting sugar, added sugars, and saturated fats. Can you address strategies for addressing this situation?
So triglycerides can go for lots of different reasons, and diet is one of them. And you mentioned two things that can increase triglycerides: saturated fat, although despite the fact that we think of triglycerides as fat, saturated fat is usually not the most common cause of elevated triglycerides. It's simple sugars, because they get converted into triglycerides. In people who have inherited abnormalities that cause high triglycerides, they are more sensitive to saturated fat, but that's less common. But alcohol can increase triglyceride levels. And so anyone who's drinking more alcohol, that's a concern. Estrogen can increase triglycerides. There are a variety of other medications that are associated with higher triglyceride levels: beta blockers, certain blood pressure medicines, diuretics sometimes can do it, medications used for acne, medicine that used to be called Accutane can raise triglycerides. And so there are a variety of different factors that can raise triglycerides. And often it's what we call multifactorial. it's not one thing, but it's the perfect storm of several things, maybe with a slight inherited predisposition. And so when triglycerides are up, they represent a risk factor for heart disease. High triglycerides are a risk factor for heart disease. And the first thing to do is try to sort out why it's going up. And then the next thing to do is focus on reducing risk of heart disease in that setting.
Great. So this question is for Ron. Somebody wants to know, what are some of your go-to meals for eating healthy and watching your cholesterol?
Well, you know, my mother used to raise me on oatmeal in the morning, but then I find out that oatmeal is a carbohydrate, and I'm finding that excessive oatmeal will give you increased sugar, which I'm concerned about that right now. So I've switched to egg whites and vegetables. It sounds kind of boring, but I switched to egg whites and vegetables for breakfast. It's helped with my weight control. I've lost 7 pounds. Of course, we all know that eggs have cholesterol in the center, and it's 350 milligrams per egg, so it's not a good idea to chomp those down. So I switched to egg whites and vegetables in the morning. I've also, since I'm a vegetarian, I look for the non-meatless situations of burgers, which you got to be cautious because it is processed food. And I still have fish. I don't eat much past 4 p.m. in the evening because it just turns to fat. And so I'll load up morning heavy, moderate lunch, and a light dinner, but say it's about 4 o'clock now. I'm not going to eat much past 4 o'clock to watch my weight because my A1C is up to 6, and they told me I'm pre-diabetic. I definitely knew I want to go in that direction. So it's kind of hard to manage, but you have to be tough. And of course, if you got sugar issues, you got to stay away from the sugar. I've been a sweet eater my whole life. I tell you today that I cheated and had a donut along with an egg white sandwich, and that was not good. But but I hadn't cheated for a while, so every once in a while you could do that. But basically, you have to stick to low-fat diet. Since I have a Hispanic origin, I like salsa in my food, so I'll put salsa in there for flavor because it can be get yourself in the bland diet. I hope that answers some of your questions.
Great. Love salsa. And pico is my new go-to flavoring for everything. So, okay, this one is for the doctor. Why is there so much resistance to taking statins?
Oh boy. I got to be very careful how I answer this one because I'm very sensitive to it. But there is a lot of negative information out there, much of it in social media and online about statins, and most of it is inaccurate. And I say that, you know, in a way that's important because I think that people pay attention to stuff that they see in print or online. If it's in the newspaper, if it's on the internet, people tend to believe it. And you always have to kind of try to make sure that when you see or read something, you understand its source and you track it all the way back to where it is. And if someone's telling you that statins are bad and they're telling you it because they want to sell you something, whether it's a dietary program or a book or something like that, just be careful of where the information comes from. Statins have side effects. There's no question about it. But statins also have dramatically changed the way we manage and treat patients with heart disease. And, you know, statins are generic medications, so that these medicines are available now for small amounts of money. Drug companies have stopped promoting them. Yet for some reason, people still try to create these links. And, you know, I think it's important to always try to source your information accurately. And that's the best I can tell you.
I would like to add to that.
My colleagues struggle with this.
Yeah, I'd like to add to that. You know, I come across a lot of men that give me a lot of that same. And in my answer to them, I'm still alive. And I have to say that because I've been taking statins for a lot of years and I'm still alive. The numbers are good. And if you already have high risk and going that direction, the chances, and I could say it, probably not the doctor, the chance of your heart attack raises. right? So you have to balance between, you want to take a statin and worry about some muscle pain on your legs. Yeah, we get those. Or do you want to have a major MI? Is the balance between those, because the numbers will show. I don't know of anybody that as their numbers start increasing that don't run into trouble, as they get older. So you have to balance those two. I've been on statins for years and I'm fine. I exercise and I watch my diet. So you just have to balance that, because the alternative of getting a heart attack is not fun. Having major clogged arteries is not fun. In a recent visit to an angiogram and to tell me that I haven't improved, that I'm still in bad shape, is not fun. So these are the results. So I hit them pretty hard, and I'm just my goal is to try to save lives the best I can.
I'll tell you that when I first went into practice, I used to go to the emergency room once a week to see a patient having a heart attack. Knock on wood, and I'm looking for some wood here, I can't think of the last time I had to go to the emergency room to deal with a patient having a heart attack. And I think the biggest change, along with diet and lifestyle and information we've learned about that, is the intervention of statins over the last 30 years. Any other questions?
Oh, I'm sorry, I was muted and I was talking to myself. I know that we're almost at the top of the hour, and so I just want to get through a couple of more questions really quickly. The one here is, other than statins, are there any other cholesterol drugs that lower inflammation in CRP?
Right. So interestingly enough, the newest medication that I just talked about, bempedoic acid, does lower C-reactive protein, which is a marker of inflammation. Whether that is a beneficial effect of it or not has not been determined, because this new drug, while it lowers LDL, has not yet completed a clinical trial showing that it reduces the risk of heart attack and stroke. When you add ezetimibe to statins, you see a further reduction in C-reactive protein also. So those are two potential options out there.
Great. This is a great question. And so somebody wants to know, is it okay to split statins in half to save money? For example, an 80 milligram Lipitor only costs a little more than the 40 milligram. So if I'm prescribed 40 milligrams a day, can my doctor prescribe me an 80 milligram tablet and I take half of the tablet, which is 40 milligrams per day?
Yeah, there's no reason you can't split statins. We did it for a long time when they were branded medications and they were very expensive. But even now, as generic medications, it does save some people money. And so if they can do it accurately, there's no reason not to.
Great. Okay, dietary supplements, good, bad, or big expensive snake oil?
I would say be cautious. There's no requirement to document anything that you say when it comes to dietary supplements. And so one has no way of knowing if the claims are accurate and if what's in it is actually what people say is in it. And so I'm extremely cautious with dietary supplements. There's not a lot of good data showing that dietary supplements do much of anything with regards to cardiovascular outcomes. Recent studies with vitamin supplements have not been forthcoming. And so I say tread with caution.
Great.
Doctor, if I could chime in there, I probably could say more than you can, but the fact remains is when I was younger, I used to spend thousands of dollars on vitamins and supplements and vitamin E and vitamin C and all that. And my answer to those that are doing that, and I had a heart attack. So the fact is they don't work. And we think they work, and it's kind of a placebo. You know how you do the placebo is you think they work. The only thing I do still take is a multivitamin, but I've got rid of all the other stuff because there's a danger I don't get enough protein, and that always is an issue for me, that they don't work. So it's best to do the three that we talked about, in my opinion only, is exercise, diet, and medication. And without one of those three, you're heading for trouble.
Right. All right, one more question that we will take is, what to do if your triglycerides are still high after diet, exercise, Vasipa, and Venofibrate. Sorry, I slaughtered that word.
Fenofibrate, yeah. So fenofibrate or fibrates and fish oil, omega-3, prescription omega-3 fatty acid, actually, are two very effective ways to lower triglycerides pharmacologically. Now, some people have extremely high triglycerides from inherited causes, and statins will lower triglycerides, and sometimes we do use them. And it's one of the rare cases sometimes where I might use niacin, but I tell you that I'm very cautious with niacin because of its side effects. There are some investigational drugs that are not that far away for triglyceride lowering. And then obviously, of course, making sure there are no medications or other lifestyle issues that are playing a role are just as important.
Great. All right. Thank you so much. What great questions we've had. And we still have a lot of other questions that are in the queue. For those of you who we were not able to ask the questions, we will definitely send these along to the National Lipid Association, and they will get you the answers to the questions. And I will work with them to get you the answers via email. But I wanted to take 2 moments. One is to do our poll again, our little quiz, to see how much that you learned during the webinar. So we're going to launch that again. And that should be live on your screen. While the poll is going, actually, let me just ask one final question, because there were a couple of questions about egg yolks and low fat diet. Can you just, I know that you weren't a dietitian, but could you just talk a little bit about how much is too much eggs and maybe how somebody can go about getting that diet in order?
All right, so there is a lot of confusing data out there about egg consumption and risk of heart disease. And the problem is, like any other dietary intervention, it's confounded by what else people do. If you go to your local deli and watch people ordering eggs, as Ron mentioned, they're rarely ordering eggs by themselves with veggies the way he has, but they're ordering it with bacon and cheese on a roll with butter on it. And often people who eat eggs that way, there may be other associated behaviors that confound the data with egg consumption. From the National Lipid Association's perspective, eggs, especially egg yolks, raise cholesterol, and cholesterol increases track with increased risk of heart disease. The problem is reducing cholesterol intake for many people doesn't affect their cholesterol, but for some it does, especially for people who have inherited cholesterol disorders. And so a diet restricted in saturated fat and cholesterol, and what I tell people is minimize your egg yolk consumption to just a few eggs a week, I think makes a lot of sense. And we still make that recommendation as a lipidologist.
Great. Well, thank you all for joining us, Dr. Underberg and Ron. Thank you so much for spending this hour with us. To everyone listening, thank you for attending the series. It has been great. If you missed any of the webinars from the 6-part series, you can access them now at mendedhearts.org. If you look on the home page for the blue Beyond the Numbers logo, you will see that there, and they're all listed. The recordings are up. The PDF version of the slides are up, and any handouts that we had throughout the series. I just want to take one quick moment to thank our sponsors, Amgen, Esperion, and Novartis. They have been wonderful to support this activity so that we could get this education out to everybody. So thank you all for attending. Thank you to the doctor and to Ron for joining us this evening. And everyone have a great evening.
Thank you.
Thank you.